Hello, my name is Caitlin, and this is a training on Human Sexuality 101, working with sexually diverse clients, training for people working in human services, so therapists, counselors, caseworkers, could be nurse practitioners, doctors, whatever profession that works with clients who might bring up issues of sex and sexuality. The purpose of this training is to become more aware of the various concepts of human sexuality and be more comfortable when talking about these topics with clients. A lot of times clients will come to us needing advice or help or some sort of direction, want to see if certain things are healthy or disclose certain things as part of the relationship they have with us. And so we really need to be informed so that we can be there for our clients. Highlights of what we're going to cover in this training. So we're going to go over the sex ed basics. So just what is sex, human anatomy, masturbation, porn. We're going to review gender, relationship, and sexual diversity. So exploring the wide range of identities that can be healthy. We're going to have discussions. Since this is a recording, we're going to do just time you can pause it and kind of maybe journal or think about these things. And I just want to encourage you, if at any time this content is triggering to you, pause the video, take a break, send me a message or an email if you feel like you need to kind of chat with somebody. And then before you really start the rest of the training, I just want you to take a moment to ground yourself and kind of open your mind to these concepts. So whether that's taking a few deep breaths or a mindful meditation, whatever works for you, go ahead and take some time to do that now before we begin and at any point in time that you need it throughout the training. Why do we need this information? So our clients are coming to us needing to talk about different issues. And they may need to discuss these, they may need some guidance, they may have questions. And so we need to be aware of healthy gender, sexual, and relationship diversity so that we can really educate our clients on that. And we can also meet them where they are from a non-judgmental standpoint of knowing what really is healthy and healthy expressions of sexuality. We also need to explore our personal biases and assumptions, be aware of and challenge these. So thinking about, where am I triggered? Where is this coming from? And how can I challenge this? And part of being in human service professions is providing inclusive and affirmative practices to clients or services to clients. And so this is kind of a point where you can educate yourself to be better for your clients so that you can be confident in providing those services. Something else to keep in mind is that many clients don't disclose information related to their gender, sexuality, or relationships to therapists because of fear of discrimination or termination from services. This is a very realistic concern and has been supported by numerous research articles that a lot of times people will disclose certain things and the therapist will say that they can't work with them if they're not willing to change this, or they don't feel prepared or confident to work with the issues, or they will then stop focusing on the issues that the client is coming into services for and start focusing on things like sexuality and relationships that maybe the client doesn't need to actually focus on. That's more background information. I wanted to take a minute to talk about the state of sex education in the United States because this is a main reason why a lot of us are here and don't know this information. So sex education is not currently mandated in Indiana. It is not mandated in a lot of states. If it is taught here, it must emphasize abstinence. It's not required to provide information on sexual orientation, gender identity, or even consent. Schools must make 2 attempts to receive written permission from parents to teach their kids about sex education. And the information taught is not required to be medically accurate. So a lot of what you learned in sex ed could potentially just be myths and has no scientific standing. So that's kind of a scary thing to learn, that a lot of what kids are still learning even today in school doesn't have to be truthful. And so I just want you guys to think about how this lack of information might affect us as professionals. Knowing that your clients probably had this information growing up too, how do you think it affects them? And how does it affect kind of the dynamic between the relationship between therapists or human service workers and their clients? As a starting point, this is just a reflection that you guys can do internally. Think about where your biases and assumptions are coming from into this training. So what biases do you already know you have? Do you have certain biases against non-binary people or polyamorous people, people who engage in the swinging lifestyle or BDSM? What views do you have? And I want you to also think about where you learned about sex and sexuality growing up, what gender, sexualities, and sexual activities you consider to be normal, what you might consider to be reason for concern. And then think about, do you avoid certain conversations about certain topics or issues? So if a client brings up that they're a sex worker, do you kind of engage with that? Do you see where that goes, if they need any help with that, or if that's just purely their profession? Or do you really avoid that? Do you kind of shut down? And then think about what assumptions you make about healthy relationships. So if you were to think about a healthy relationship, what are you assuming that looks like? The basics. So this is stuff you may or may not have learned in sex ed, especially if you got your sex ed in Indiana. I'm going to guess you probably did not learn most of this. What is sexual health? So according to the World Health Organization, here is their little blurb about what sexual health is. A state of physical, emotional, mental, and social well-being in relation to sexuality. So notice that it kind of covers all of those domains, right? Not the abstinence of disease, dysfunction, but it requires a positive and respectful approach to sexuality and sexual relationships, the possibility of having pleasurable and safe sexual experiences. So notice that in their definition of sexual health, they include pleasure, free of coercion, discrimination, and violence, and saying that the sexual rights of all persons must be respected, protected, and fulfilled. This is something that's really important that, again, a lot of us probably didn't learn in sex education. So this is the 6 principles of sexual health. If a client comes with any type of concern about sexual activity not being healthy, this is what I like to go over with them and kind of dive in with them. So here you'll see we have consent. So that's the mutual agreement to engage in a sexual activity. And making sure that people consenting are able to consent, right? Are they under the influence of drugs or alcohol? Are they underage, right? Can they actually consent? Non-exploitative. So one person's not leveraging power and control to receive sexual gratification. So you don't have a professor saying that they'll give you a better grade if you engage in a sexual activity with them, or a boss who is expecting you to engage in sexual activity with them for a promotion. Honesty, so being open and direct with your communication with yourself and your sexual partner. So this might include something like sharing your STI status or the date of your last testing, so being honest. Shared values involving motivations for sex and meanings of activities. So do you both agree that you're having sex because you're in a relationship, or do you both agree that this is a hookup? Does one of you think this is a hookup and the other one thinks that this is going to be a long-term thing? So making sure the values for everyone involved are shared. Protection is planning and taking precautions against STI, HIV, unwanted pregnancy, all that stuff. So again, getting tested, using condoms, dental dams, that sort of thing, to make sure that everyone engaging in the activity is protected. And then pleasure, so balancing the sexual safety and responsibility with pleasure, exploration of interests, and all of that stuff. So what is sex in the first place? It's kind of funny that we go through sex education, we're talking about sex, and a lot of us don't even have a solid definition. And this is something that is so diverse. Researchers have tried to come up with a singular definition, and one really doesn't exist. There's a lot of different ones that are good and encompass a lot of different things. But what are we typically taught? We're typically taught that sex is the penetration of the vagina with a penis. So very heteronormative view of sex. Doesn't really involve other relationship styles or all the wide arrays of sexual pleasure that people experience in different activities. So there's really no clear definition, and it's different from everyone. There's this really good YouTube video that kind of goes into depth explaining that, and you guys can watch that afterwards. I'm not going to play it for you right now, but just know that it's definitely much more than penetration, and it can be whatever brings you pleasure, whatever brings you connection, and however you want to explore that. We're going to go into some not so basic genital anatomy that you might not have learned. I think in a lot of sex ed classes, we kind of see like the internal vagina, the uterus, fallopian tubes, that kind of thing. But a lot of us aren't shown this outside view of the vulva. So we don't really know, like, here's the clitoris. The clitoris is covered by a clitoral hood. You have the urethral opening, which is not the clitoris. A lot of people think that the urethral opening is a clitoris, and those are not the same. So your clitoris is above, then you have the urethral opening, and then the vaginal opening. For the penis, you have the shaft, you have the glans, which is typically covered by a foreskin. If the individual is intact, the foreskin has both an inner and outer layer. It has a ridged band at the tip that helps protect from contaminants from going inside of it. And it has a frenulum, which attaches the foreskin to the head of the penis, which is very incredibly sensitive. Some more not so basic anatomy. Here you can kind of see I drew a clitoris and a penis to show that it's all the same parts, just arranged differently. And intersex genitalia would have these same parts, just arranged somewhere in between these two variations. So you can see the foreskin is the same material as the hood of the clitoris. You have the hood of the clitoris, or the clitoris tip and the glands. You have the shaft of the clitoris and the shaft of the penis, the bulbs and the crus of each of those. Masturbation. So what is it? It is touching yourself for sexual pleasure. It is something that is completely normal and healthy. So you don't have any risk of getting pregnant or STDs from masturbating. And research shows that masturbation is good for both your mental and physical health. There's a lot of positives to engaging in this behavior. However, this behavior is often shamed, and a lot of people are made to feel guilty or bad when they masturbate and kind of have this sense of shame and guilt. But really, it is good for you. It releases endorphins, hormones that block pain and make you feel good. So this can help release sexual tension, reduce stress, improve sleep, improve self-esteem, body image, relieve menstrual cramps and muscle tension, treat sexual problems, strengthen the pelvic floor muscles, and so much more. It also is the best way for you to learn about your body and your pleasure. And learning about your body and your pleasure is going to help you when you're engaging in sexual relations with others, because then you can teach them, like, where to touch me, what feels good, what do I like, and you can have a much better sexual experience that way. How often to masturbate? That's a question I get so much. So some people, some therapists and caseworkers get really concerned when their client says they're masturbating every day. Some people masturbate very rarely, maybe once a month or a couple times a year. Other people masturbate every day, multiple times a day. And these are all healthy variations. When does it become too much? That's when it starts getting in the way of other life things, right? So if it's getting in the way of work, school, responsibilities, your social life, then it might be too much. Think about other things, right? So if you're on social media too much, it's too much when you're neglecting your work responsibilities, or you're not getting schoolwork done because you're scrolling through Facebook, or you're not really having a social life because you're just sitting on social media. That might indicate there's a problem. But if you kind of check into social media a couple times a day, scroll through for 15, 20 minutes, spend an hour a night on social media, is it really cause for concern, or is that okay? And so it's different for each person. But something that I want everyone to get comfortable with is the fact that your clients are likely masturbating, and that is okay and that is healthy. And we don't need to make them feel shame for that. So why do people have sex or masturbate? Pleasure. We have sex, we masturbate to feel pleasure. Can also be to connect with ourselves and with others. So a lot of times in sex ed, we're taught you have sex to make babies. But in reality, most of the time, people are not having sex to make babies. In fact, they're having sex and doing everything possible to have sex without having babies. So sometimes we're told that sex is something done in marriage to connect with a loved one in a monogamous relationship, but this leaves out the other wide arrays of healthy sexuality, such as solo sex, masturbation, group sex, hookups, which are all equally valid, as long as those people feel like that's what they want. They're following the 6 principles of sexual health, and all of those good things. So just remember, there's no hierarchy. Sex between 2 married people is not better or worse than masturbating or hooking up. Those are all valid and healthy ways to express your sexuality and feel pleasure. Pornography, another thing that gets brought up a lot, both within people seeking help and clinicians being concerned about clients. Pornography is viewing sexually explicit materials. This can include videos, pictures, or even reading erotica. Porn is for fantasy and entertainment, and it often accompanies masturbation. A lot of people think that porn's problematic, but it can be healthy. The issue with porn comes from a lack of communication with partners about the use. So maybe one person thinking that porn use is unhealthy and the other one engaging in porn use behind their back because they don't want their partner to know about it. There's personal and religious values that come into play. So if you're growing up in a very conservative religious community and you are taught that porn is very bad your whole life, and then you're engaging in porn, you're going to feel a lot worse about it. And you're going to feel guilty. When someone gets all of their sex ed from watching porn, that's also not great because porn is for entertainment purposes. So it's like watching an action movie, right? It's not real. That is not how you really engage in stuff. It is purely for entertainment, and you also need to make sure that you have a good understanding of healthy sexuality outside of that entertainment. So most people can watch ethically made porn for entertainment with absolutely no issues or negative outcomes. So the things to address if porn is causing problems: are there value discrepancies there between the porn use and what you believe you should be doing? Do you have the proper background for sex education? Is there some stuff you need to learn? And where are you getting your porn? Is this ethically made, or could we direct you towards some more ethical sources for that porn? Consent. Consent is a mutual agreement to engage in sexual activity. This is super, super important. All individuals must be able to provide consent. Age is a big one. The age of consent in Indiana is currently 16. So this is the legal age that an individual is considered mature enough to consent to sex. If someone has sex with someone under the age of consent, it's considered statutory rape, even if both partners are under the age of consent. So one of my backgrounds is that I used to work for DCS, and we would see a lot of reports like this where there would be two 15-year-olds engaging in sex. And so it would be kid 1, perpetrator and victim. Kid 2 is also the perpetrator and the victim of sex. So that's very interesting, something to look out for and make sure that youth are aware of. Is that there is an age of consent here. It is 16, and there are some risks to engaging in sex before that or with people of different ages that could have legal repercussions. Inpatient settings, such as if you are an addiction and recovery unit or a psychiatric hospital, you're not really able to consent while in these settings because you're very vulnerable in that inpatient setting. So you're there for a reason, right? You are having a lot of personal issues that you need to be working on. You might not be psychologically stable at that time. That's why you're there, to kind of get stable. So that is where consent can kind of get messy. Consent phrase from Planned Parenthood is something that I really like to use. So consent is freely given, reversible, informed, enthusiastic, and specific. So that is a good one to teach. Again, if you guys want to think about how can you use the information we just talked about and the 6 principles of sexual health in your practice, this is a good time for reflection. And then we're going to move into this next section, which is diversity in sexuality, gender, and relationships. So understanding the wide array of healthy identities that exist. Some basic terminology here, just so that you can kind of get an understanding of where we're going. Sexuality often refers to the type of people one is attracted to. So gay, straight, bisexual, pansexual, asexual, those are all sexualities. Sex is the biological understanding of male, female, or intersex, typically what a child is assigned when they are born. Gender is a social and cultural construct. Gender identity is one's internal sense of self as masculine, feminine, both, neither, other, all of those things. LGBTQ+ stands for lesbian, gay, bisexual, transgender, queer, and everything else in between. So it's kind of this alphabet soup of all of these identities, which brings us to GSRD, gender, sexuality, and relationship diversity. So that kind of encompasses everything that LGBTQ+ is trying to encompass. Just shorter acronym. The binary model of thought. So a lot of people generally understand gender, sexuality, relationships in a black-white binary model. So we make assumptions about people based on this binary model. We think that gender means you're a man or a woman, sexuality means that you're straight or gay, and relationship means that you are monogamous, you have a bond with one person, or you're single. And that's either or, there's really no middle ground. However, there's a lot of issues with the binary model. So those who do fit into the binary model may adhere to these norms so rigidly that it negatively impacts their mental health. So they have a fear of stepping outside the norm, right? I can't possibly paint my nails as a man because then they might think that I'm a woman, right? So we're very rigidly adhering to these gender norms. Those who do not fit into this binary model completely may face discrimination. So if I'm non-binary, don't identify as either a man or a woman, I may face discrimination in multiple areas of my life because people don't really understand that. And then those who fall completely outside these binary models often struggle due to being invisible within the wider culture. So their existence is questioned. So let's think about non-binary people have to choose between men's and women's bathrooms, men's and women's treatment groups, treatment centers, or asexual people going to a therapist or a doctor and them thinking that, oh, we need to fix your sex drive, when really this isn't an issue that they need treatment for. So another question for reflection is, how does this binary model impact patient care? How have you seen it impact patient care? How have maybe you perpetuated this binary model previously in care? And just kind of think and reflect back on those. Sexual orientation refers to attraction. So straight, you're attracted to people of the opposite sex or gender. Gay, attracted to people of the same sex or gender. Bisexual, attracted to people of the same and other genders. Pansexual, attracted to people regardless of gender. And asexual experiences no romantic or sexual attraction. Again, it's a spectrum. It's all a spectrum. So asexual there are like so many breakdowns of sexuality within the asexual spectrum. So maybe some people experience romantic but not sexual attraction. Sometimes they experience sexual but not romantic attraction. And just there's such a wide array. So definitely, if you're interested, dive deeper into that with some of the resources that I'll provide you. Sex and gender. So again, social construct. Gender is a social construct. There's norms and ideals that are heavily based on the time and culture that you are in. Culture is what links sex with gender. So our culture says that if your sex is a female at birth, you're going to love lots of pink stuff, right? We're going to put you in dresses and pink stuff and bows. And our culture says that if you're born a boy as an infant, we're going to put you in blue stuff and truck toys and all of that stuff, right? That's what our culture says. But if you go back hundreds of years, it was the opposite. And the boys were all put in pink and all the girls were put in blue when they were born. So it's really, really culture and time period driven. So the typical gender options is man, woman, or boy, girl. And cisgender means that the person identifies with the sex or gender they were assigned at birth. The gender expression is how people communicate their gender to others, typically through clothes, hairstyle, voice, secondary sex characteristics, all of that. Continuing on with this, we have intersex, which is someone who biologically does not fit into male or female. So they may have genitalia representative of a mix of typical male and female genitalia. Their chromosome makeup may not match their genitalia. Hormones may be different than what we would expect in a typical male or female. Transgender is typically thought of as male or female to male or male to female or female to male, defined as someone who does not identify with the sex assigned at birth. So it might not be that binary, I was born a male and now identify as female, or vice versa. It might be I was assigned male at birth and now I identify as non-binary because I don't identify with the gender I was assigned at birth. Gender fluid, non-binary, agender are all ways of saying they do not ascribe to or fit within the gender binary model of male or female. Again, there are some short videos on pronouns and intersex identities that you can look back on if you want to learn more. This is one that tends to really start to trigger people. So we talk about, like cisgender versus trans. We talk about gay versus straight and the different sexual orientations. But when we get to relationship diversity, for some reason, people get really triggered. So take a moment to breathe and kind of figure out if you're feeling some sort of way and why that might be. And we're going to dive in. So relationships are extremely diverse, especially depending on the culture that someone's a part of. Every relationship is different. Our culture and our time period now tends to assume and value monogamy. Monogamy is a romantic or sexual relationship with one other person. It's interesting that this is actually a fairly recent phenomena in the whole scheme of human history, right? So monogamy didn't emerge in its current form of a man and a woman or one person and another marrying for the purpose of love until the late 1800s, early 1900s. So currently some version of monogamy is most prevalent in America. Non-monogamy is the romantic sexual relationships with more than one other person. CNM is consensual non-monogamy, which can involve polyamory, swinging, open relationships. And I just want the takeaway from this to be that monogamy should not be assumed to be the norm or the goal for our clients. Research suggests that up to 25% of Americans have participated in consensual non-monogamous relationships at some point throughout their life. And your client may be polyamorous or otherwise open. This can include solo polyamory, kitchen table polyamory, a committed relationship with two or more individuals, and so much more. So the biggest takeaway is don't assume, if your client says they have a partner, don't assume it's the only one. Maybe ask them about other partners. On intake forms, include spaces for more than one partner, just so that they don't feel like that's the assumption and they have to hide this really big part of themselves from you when they're trying to get help. Another potentially triggering one for some people is BDSM. This stands for bondage, discipline, dominance, submission, sadism, and masochism. Many think if someone engages in BDSM, it's due to trauma or past abuse. And we want to be very careful that we don't assume BDSM is part of an individual's presenting problem. A lot of times it'll be completely unrelated. It's just something they like to do. It's a hobby. It's something they engage in. Research shows that people who engage in BDSM are just as healthy, if not more healthy, in a variety of life areas than those who do not. This is likely due to the amount of communication and negotiation that must take place in BDSM settings. And 74% of people who seek therapeutic services, it has nothing to do with their BDSM identity or behaviors. So this is just really background information for the majority of clients who engage in these behaviors. Diversity, fluidity, and self-determination. So keep in mind that gender and sexuality are diverse and fluid throughout one's lifespan. Many factors play into one's sexual and gender identity, but these identities are self-determined and only the individual person can select labels for their identities. It is not your job or anyone else's job to label an individual based on what you think they identify as. It is their job to come up with their own identity and tell you what they identify as. It's essential not to assume someone fits into presumed cultural norms, for example, that they are cisgender, straight, or monogamous. And this information should be asked upon intake and updated as often as necessary. The client may not choose to tell you right away until they get comfortable with you that they have some of these identities. So disclosure. Recognize that gender and sexual minorities often experience trauma, stigma, discrimination related to their identities. So because of this, they may not disclose anything until they feel safe and secure in their relationship with you. It is likely these minority clients will present one way for a period of time before disclosing their identities. Once they do disclose, it is incredibly important that you respect them and their identities. When it is safe or you want to be sure you ask them, who is it safe and okay to use this identity around? So for example, if you're working with a teenager and they come out to you as gay or they come out to you as trans, is it okay when I'm talking to mom to mention these things? Do you want me to use these pronouns around mom and dad or some other pronouns? What name do you want me to use when talking about you to your parents? And that's just one example, but it is very important to ask those questions because there may be instances where it's dangerous for that client to be out with their identity. So make sure that you note this and be very careful when discussing this. Affirmative practice. So how can we be affirming to our clients given this information? Don't make assumptions. Always ask. So example, client's name, pronouns, their partner, their relationship. Ask them and make sure you show respect when they tell you. Normalize asking for and providing pronouns. Add them to your email signatures. Add it to your intake forms. Ask and give when doing introductions. So if you're meeting new employees, if you're meeting a new client, make sure you be like, hey, my name's Caitlin. My pronouns are they, them, or she, her. What name do you go by and what are your pronouns? If you have a client and you have a team working with the same client, make sure you correct others when they use the incorrect pronouns. So if you have a client that goes by he, him, and somebody in private is referring to that client as she, her, just politely say he, him. Their pronouns are he, him, and make sure to correct them. This may trigger some people, but it's really important that we stick up for our clients and use their pronouns and their name in all settings when they're there and when they're not there. And then avoid making assumptions by using gender-neutral terms. So this can be on intake forms or when talking to clients. Instead of saying, what does your husband do? Say, what does your spouse do? Instead of saying, who's your mom, who's your dad, who are your parents, right? Instead of ladies and gentlemen, you can say everyone. Instead of brother or sister, say sibling, things like that. And then make sure you're normalizing and empowering clients rather than advocating for culturally normative values and beliefs. So really normalize this diversity and empower their clients to advocate for themselves. So don't just advocate for the clients, but teach the clients how to advocate for themselves in these settings. Intersectionality is very important. So you have intersecting identities along with sex, gender, and sexuality. Things like race, class, ethnicity, religion, language, immigration status, ability, disability, all of those things. And understanding and integrating each of the client's identities into treatment is going to be very important because that is how they exist within the world. So that's really using an intersystems approach to working with your client. Trauma with gender and sexual minorities. So this is important to note that LGBTQ individuals report twice the amount of adverse childhood experiences, higher rates of childhood sexual assault, physical assault, and emotional abuse. This population faces oppression, marginalization, lack of protection, lack of access to resources in school, work, faith, and other community settings. LGBTQ plus individuals are disproportionately homeless, especially among youth and young adults. This often has to do with family discord because of their identities, parents who are not accepting, maybe kicking them out, them not feeling safe or welcome in their homes. They also have higher rates of suicidal ideation and suicidal attempts. And then support is an essential protective factor for this population. So if you can be a person to provide support for anyone in this population, you are going to dramatically help them not be a part of the statistic. Trauma-informed practice. So recognizing that trauma and violence impacts individuals and it impacts the coping skills that they have access to. Center recovery from this trauma as a primary goal for treatment. So this, if an individual has trauma that they're dealing with, this is something that really needs to be addressed while they're in treatment. An empowerment model can really help those who have been disempowered by their trauma. So really giving the power back to the client. Prioritizing client choice, voice, and control while in the relationship. So not telling them what they need, but asking them what they need. Offering suggestions, but really letting them guide is important. And then you want to ensure approaches and practices are rooted in relational collaboration. So collaborating, again, with the client, not directing them what to do, but it's a collaborative approach. You want to create an area that is safe, respectful, and you want to create an atmosphere of trust within the therapeutic relationship. Minimize re-traumatization. And this is, again, where all of that stuff you just learned is really going to come in handy because you don't want to re-traumatize them by making assumptions or trying to, quote unquote, treat their identities that really don't need treated. You really want to meet them where they're at and accept them for who they are. And then a focus on strengths and resilience is going to get you really far. So what has the client gotten through? How did they get through those things? And what strengths do they have that's going to help them to continue to get through things throughout their life? Queer theory, this is one of the critical theories, focuses on systematic inequality faced by minority groups. Queer theory helps practitioners examine a client's presenting problems from a perspective that recognizes the social inequalities they face and that plays a major role in their lives and in their treatment. Queer theory also provides a framework to question concepts of identity, gender, and sexuality, like we talked about earlier. It focuses on sexuality, gender, power dynamics, and classifying identities, and it helps question the dominant ideals of gender, sexuality, and relationship structure. So what do we do with minority stress theory in clinical practice? Know that sexual minorities have higher rates of anxiety, mood disorders, and substance use. Minority stress theory proposes that sexual minorities deal with chronic stress because of homophobic and heteronormative society. These mental health issues often result from or are made worse by discrimination and prejudice that is faced by minority clients. Some policy considerations, if you work for an organization, things that you can advocate for, mandate non-discriminative policies. Make sure that insurance companies are listing affirmative resources or providers, making sure that there are lists that people can use to find these affirmative resources and providers so that they are informed and can know who to go to safely. And then for clinicians, acknowledge and recognize how minority stress impacts your clients and use the specific framework necessary. Clinical framework for the minority stress model. First is the assessment of minority stress. So assessing the exposure to prejudiced events, stigma, internalized homophobia, sexual orientation, concealment, and all of that stuff. So just do a general assessment. How has this affected the client? General assessment, the coping and emotional regulation, social and interpersonal cognitive that your client is coming to you with. And then an affirmative treatment, build that therapeutic relationship, address that stigma that they may have faced. Hopefully the sexual orientation is disclosed to you, and so you can help the client focus on coping, improving social skills, and process that therapeutic relationship. And so at the end, this brings us to another discussion and reflection. What did you learn from this training that you didn't know before? So what's one thing that you did not know that you know now? How can you integrate this information into your work with clients? And that's a big thing that I want everyone to focus on, is how can you really integrate it? Now you know this information, how are you going to use it going forward? And then how can you incorporate this information into your own life? Is there some stuff that you learned that you had not considered before that you might use now going forward? Maybe it's those 6 principles of sexual health. Maybe you can really incorporate that into your relationship, into your own sexual relationships and practices. And then if you guys have any questions for me, be sure to send me an email. And then here are the references I used. And that is everything I have for you. So thank you so much. And I hope you learned something and that you enjoyed this.